The preceding presentation is a series of training sessions held over 2 different weekends by the Medical Coding Institute. Please enjoy. My name is Kevin Vassiana. I am with the group Medical Coding Buddies, and I just launched a company called Medical Coding Institute. And the goal of the company is to provide continuing educational units to individuals who wants to continue to learn and offer CEUs and etc. on the platform. So I'm going to be utilizing this platform to do this on a going forward. I've been with Medical Coding Buddies Group now since its inception back in around 2018. I've launched this, me along with Celeste. I've been doing these trainings, and I've done a lot of interactions on the platform. For those who are new to the group or who have been with us for a while, have seen the different training events that have taken place on the platform. A lot of individuals have passed their CCS and CPC because of me. And that's not bragging. That's just putting out there. Bianca, you're one of the longtime ones. You know how this platform works, and she can more than likely testify as to what happens here. And so I've been doing a lot of the events. Hopefully, in the last year or so, I had to slow down because of work. So you have been seeing a lot of live events on the platform for a little bit because of work, and the schedule has really got into the way, because now I am an adjunct instructor with a college in New York. So I teach at Bryant and Stratton College in New York as an instructor, and this is all online. And I have multiple classes running with them. On top of that, I have my day schedule with my regular job. So so I do a lot of different things, and working from home allows you to be able to do that. And I mean, you guys, I kid you not, have really been the one that helped motivate me to keep on pursuing other avenues, because once I come on here and I teach and I tutor and do all of that stuff, it motivates me and drives me to do more. And so because of that, I went out and got my master's in healthcare administration last year. For those who with me last year, when I announced that, I obtained my master's and in healthcare administration, specializing in informatics. And so I was able to achieve that. And because of that, now I am an instructor with a college. So that's a quite an accomplishment during the pandemic. So I thank God that I am still here and able to continue to help you guys. And I will never leave you guys or abandon you guys on this platform, because we have grown now to over 5,000 people on this platform. And I'm hoping that it continues to grow. And I want you guys to continue to bring all your fellow classmates, your fellow co-workers onto the platform to continue to expand it, so we continue to offer free advice and etc. Along the way. We will have these CEU educational products. Unfortunately, this one is not a CEU approved, because of the fact that there's really nothing to do with training on a platform. You can't really, a lot of the stuff or the information that I'm going to bestow on you is copyrighted by 3M. So it's really not much I can do where that is concerned when it comes to training. All I can do is just give you this hands-on tool. So somebody asked earlier if there's going to be PowerPoints. Well, not really. I can't do PowerPoints on this, because any information I take from them is going to be heavily copyrighted. And so therefore, you know, a lot of this stuff is they rely on you be on the job to be trained. So you have to be on the job, just like Epic. Somebody asked me at one point, can we train on Epic? The answer is no, because Epic, I checked into it. The way Epic is set up is you have to be working for a hospital system that has Epic and allows you to be trained on Epic, because I think they have a lingo, you have to be Epic separate certified or something to that effect in order to work on their platform. So they really take it seriously with that platform. But I understand is the new wave. A lot of hospitals are pushing towards that platform now, but the 3M product is never going to go away, because it's one of the tools out there that's the easiest tool to utilize. Folks always going to be utilizing this. You have the 3M encoder, all right, and then you have the functionality with the 3M encoder is that you can actually embed this into the patient's charts, and it allows you to pull up their data automatically. And it has the ability to also interface with the actual medical records. So once you launch an account in whatever software platform you're utilizing for your hospital system, it automatically pulls up the medical record along with the patient data, so you don't have to plug it in. So on this page that you're looking at right now, this encoder, you will see that it has the gender, it has the age and admission, the admit date, the discharge date, the length of stay, the total charges involved in that, and whether or not you're utilizing the general hospital system or whether or not you're utilizing a DRG finder, what type of product you're utilizing, and the grouper software that you're utilizing. So a patient A male, comes into the hospital to be seen because he has a fever, runny nose, headache, and the final diagnosis is acute sinusitis. Then you will automatically, in your software at your entity, wherever you're working at, will be able to see those demographics already inside the platform. You do not have to plug in any of that stuff. All you need to do is go in, put in your reason for a visit or your admit fields diagnosis along with your principal diagnosis based on the what's in the medical record. And then you go forward and you finalize that account and you move on to the next one. So that's how the system is set up. So it doesn't, you're not going to be inputting any front end information, whether it be the age of admission, the female, the sex rather, the admit date, any of that stuff is not going to be inputted by you. In some softwares, you may end up having to input the discharge status. It depends on the entity that you work for. So some entity, you may have to input the discharge status. Discharge status means where the patient goes at the end of the visit. Where did they go to? Did they go to a nursing home? Did they go to a rehab center? Did they go to an ALF? Or did the patient just go home on his or her own? Those are the type of situations that you may have to capture on your own. You may also have to input the physician at the time of service. And in some cases, depends on the entity again and the backend software they're working with, you may have to enter the consulting physicians, the actual internal medicine doctor that actually treat the patient on the floor. So when you go into an entity, a hospital, you will have one main doctor. That's going to be the doctor that sees you throughout the stay, right? And we call them the internist. And then you'll have the consultant doctors. So these are going to be many different doctors that comes in over the next several days to visit you in order to take care of you. So there, it could be a pathologist, it could be a radiologist, it could be, and the list goes on. I mean, nephrologist, etc. It depends on the situation surrounding your care. Those doctors may be consulted to come in and render care to you. Okay, so in that case, you may have to input those doctors inside whatever system, backend system you're working with. So when I talk about backend system, what I'm talking about is this. You're going to have an encoder class. You're going to have an encoder that captures your medical diagnosis, but you're going to have a backend system, your charge capture, where the charge capture information goes into. So whatever the hospital entity embraces is what you're going to utilize. So for example, Epic, all right, and that kind of thing. So that is going to be your backend. Now, so the backend is going to be the one that basically say, listen, this is where my data is going to be stored, and then it's going to be pushed out through internet and land on a claim form somewhere and finalize and sent to billing. So if you have a central billing department that actually finalize the bill, then that's where it ends up at. And they finalize the bill, it gets printed out on either a UBO4 in many cases, or CMS 1500 claim form in some cases, which is rare for facility type. In the facilities, in the physician's offices, not many physicians' offices use this encoder. Some do. Some will embrace the like a standalone encoder to help them to code. But for the most part, you utilize a charge capture sheet. That pretty much has the list of charges already printed out for you, and you just circle or highlight, and then somebody goes ahead and plug them in, or it could be you that plug them into the computer utilizing either WebMD or Medisoft or whatever the case may be, product you utilize for your doctor's billing, and you push those out on a CMS 1500 claim form. So But for the most part, in the facility side, you're going to be pushing these out on a UB04 claim form. And everybody here understand the difference between the two claim forms, correct? Does everybody understand the difference between the two claim forms? Okay, so I don't need to explain that. So has anybody been introduced to the 3M encoder before?
We have it at work, but we hardly use it.
Okay, so Bianca, I mean, I know we talked before, so I know I've introduced it to you before. And anybody else?
Yes.
I have not.
So I think we have what? Somebody said yes, they have been introduced to it. Was that Ruby?
Yes.
Okay, so you use it daily?
Well, not daily, but yes, we have it.
You have it. Okay. All right. So let's go through the product bit by bit so you can understand the breakdown. And then we're going to break down. Once we get into the hands-on now, what I'm going to be doing is going to be tossing the mouse to you. And then I'm going to throw some terms at you and you're going to practice around with it. The key is once you get down with once you get to your turn and you finish, then you can feel free to log off for the day, or you can stay on and watch others practice. So it's totally up to you. But let's walk through it, the encoder, and we can show you how it's set up. So this is the encoder. Again, the information that's plugged in here is relevant to what is going on with that patient at the time of visit. If you're utilizing a standalone, you will have to plug this information in. If you're not using a standalone, it should automatically become embedded inside your software platform that you're using on your backend. So once you go into a medical record, it automatically launches, and then information will be already there for you, so you don't need to plug any of this stuff in. So if you're working at a hospital, it's going to be a hospital, right? Now, when it comes to here, if you utilize it as standalone encoder, this is very important to know. So for those who are going to be utilizing a standalone encoder, you need to know that there's two products that you need to worry about when it comes to this. There's going to be the DRG finder, and there's going to be the APC finder. So DRG is pertinent to the inpatient setting. APC is pertinent to the outpatient setting. So DRG, diagnostic related group, APC, ambulatory patient classification system. Those are your two different systems that you have to worry about. Okay, patient is over 24 hours of stay, I go here. Less than 24 hours, I go here. Okay, so you'll hear me say this when we're doing it, the training session. So DRG, then we go to Medicare. We're going to use Medicare all the time. We're going to use Medicare as our guinea pig. Okay, now I'm going to tell you this. We may run into some issues with 3M along the way because sometimes there's a lot of people on the system and we may get this message. All I need to do is just hit exit. We're going to keep going until hopefully it picks back up. So we may run into some issues with it. Then, because we're using a standalone, you need to select how the patient was discharged. Now, in an inpatient setting, some entities, you may have to input that manually. And in the majority of the cases, you will need to input that manually. And the reason is because of the fact that in an inpatient setting, the system cannot pick up handwritten notes. And not only that, it's reliant on somebody inputting it in, whether it be charge nurse or CDIs or whoever, to input that information in. That's handwritten notes, and nobody's going to be able to, the system's not going to be able to pick up on that. All right. For the most part, some of these doctors, they still handwrite notes. They don't utilize EMRs. Some of them are stubborn and they just want to write. And so you're going to have to figure out your handwriting and figure out where that patient went. Okay. So if the patient is gone home and they say the patient is gone home, then you're going to select home. And then you go ahead and you start entering the information. So the first situation, let me use one. The patient has fever. So we're going to type in fever, and then we're going to select based on what is going on in the medical record. Now, your medical record is your guide. If the doctor says fever and nothing else, then the answer is going to be fever and nothing else. So now how do we ascertain that? Based on the medical record. Now, remember the rule in coding, it says, if it's not documented, it never happened. That's a golden rule in coding. If it's not documented, it never happened. So we're going to select the letter I because nothing else was documented in that medical record. And there goes the fever diagnosis, R59. In the real world, it would be written R50.9 because we know that's how it's written in the real world. We hit the continue button, okay? And then we do the same thing here because what we just entered was the admit diagnosis. We just entered the admit diagnosis in the inpatient setting. So now we need to put in the actual diagnosis of the patient. So the actual diagnosis of the patient, hypothetically, the doctor may say the patient is suffering from acute bronchitis. So in that case, what we need to do is find the term that is going to be the one that we're going to utilize to tell the computer, the encoder, listen, this is what I want you to start with in order to end up with a code. So you can't use the word acute. Why can't I use the word acute? Because acute is too broad. It is too broad, and you're going to be here forever because it's going to say acute what? Acute what exactly are you trying to get to? So instead, we're going to start with a condition. The condition is bronchitis. So we will start with bronchitis, and then we'll select number 1. And now we know the term that was given to us. The doctor said acute bronchitis. Now, he said acute bronchitis. He didn't say it's acute chemical bronchitis, right? That's one right there. He didn't say viral acute. He says viral acute or subacute, or is it other unspecified? Well, now if you go here, this is bronchitis, not specified as acute or chronic. But because we know bronchitis is a viral condition, we select here, which is E, and because he didn't list any other conditions that's going on with the patient, we're going to select 8 for other unspecified. Then there's going to be a question as to whether or not the condition is with sepsis, and you're just going to select no. Now on this screen, you're asking, and if I'm going too fast, slow me down. Tell me I'm going too fast and I need to slow down. On this screen, it's asking whether or not the acute bronchitis, does the patient have any underlying conditions? For example, is the patient suffering from allergies? Is the patient has COPD? Is this an exacerbation of COPD? All right. Is the patient suffering from tracheobronchitis, which is a chronic condition? Or is the bronchitis due to chemicals, fumes, or vapors? If none of those are listed inside the medical record that you coded, then your only choice is to select number 1. From there, it's going to ask, is the patient a smoker? Now, majority of these has gone to the way where the encoder alone is be worldwide because of the pandemics and the stuff that we're going through. They want to know exactly, is the patient dependent on any of these products? Is the patient dependent on long-term or supplemental oxygen? Is the patient dependent on is it a smoker? Was this caused by smoke inhalation? Does the patient work somewhere where they're exposed to environmental tobacco smoke? Or does the patient have a history of tobacco dependence? If all of these answers are no, then you're going to just select number 1. And then it's going to ask you, is there a procedure, or was there a procedure that was done on this patient at one point during the stay? And if the answer is no, you select no procedures, and there goes the answer. Acute bronchitis due to unspecified organisms, J20.8, and you keep it moving. And so that's your code based on what was documented in the medical record. Now, our purposes, not the real world purposes, because this won't apply in the real world, we're just going to hit the next patient button because we're using a standalone encoder, and we go to the next patient, and we do select the age again, and that's how we're going to do our practices. But now I want to take you back into the encoder because I want to show you some other stuff. So I'm just going to plug posts in real fast. Cough got that updated this year, by the way. For those who don't know, Cough is now expanded its coding. It used to be just R05, now it's R05.9, and there's other emphasis on Cough. I did a presentation last week for those who missed it, a webinar on the 2022 coding updates last week where I went over this stuff. So let's see. So this is the encoder. Can everybody see the screen okay? Yes?
Yes.
Yes.
Okay.
Yes.
All right. So we're seeing the screen okay. If you notice, you have some icons at the bottom of the codes. See that? Codebook and coding HB. Everybody see that? So coding HB means coding handbook. Codebook is just that, codebook. If you click on it, it's going to actually bring up the code book, meaning the ICD-10-CM book without you having to own an ICD-10-CM book, because it's actually going to be there. All right, so here are your codes. Here are your new codes for cough. R0 5.1 is a new code. Now they break it down to what is acute cough, subacute cough, chronic cough, cough syncope, so meaning that the patient coughed but also had a syncope along with that. R0 5.8, other specified cough, or is it other specified cough, cough unspecified, those kind of things. So I brought you here because I wanted to show you other stuff. So along with that, inside of that is listing next to each code set whether or not it's a CC, CDRCM information, which is a coded desk reference manual, right, for clinical modification, or the coding handbook. So it brings you back to the coding handbook. All right, if you want to go to the code. So these are resources, class, that you can utilize now in order to help navigate the coding. So if you have issues, if, for example, you had a coding clinic situation that you need to look up. Everybody understand what the coding clinic, what I mean by that? When I say coding clinic, does anybody not understand that term?
Yes.
I'm not 100% aware. I'm sorry.
Okay, so coding clinic refers to this. Ruby, we have the American Hospital Association, which basically is our overseer per se when it comes to medical coding a lot in America. So they are go-to gurus. They are made up of coders just like me and you. They have their CCS credential, their CPC credential, etc. And they also may be nurses, pharmacists, doctors. They work in Washington, D.C. for the most part. And they are the ones that we will say, listen, I came across a situation. I do not understand how to code it. Please guide me. So you will send them supplemental information. You will send them a very detailed question, and they will come back with you with an answer as to how to embrace that situation in your practice, and they will put out a guidance. That guidance will say, this is what you're going to do going forward when you see this situation. These are known as coding clinics. So these coding clinics allow you to code. The coding clinics, for those who have not taken their CCS exams yet, are your final source of authority. What I mean by that, you have your coding handbooks. That's your go-to for coding. But your final source of authority, the one that really says this is how this code applies, is your coding clinics. These are the ones that says, listen, when it comes to ICD-10-CM coding, this is the one that says, this is how we're going to handle the situation. So not all codes are going to have coding clinics. So if you ever go through your ICD-10-CM book, you will see in your tablet section, some of your codes may have the listed AHA and some funky numbers next to it, like Q1, pages X, Y, and Z next to it. If you ever go to your tablet section of your actual coding book, you'll see those. That is what we term coding clinics. So the book is guiding you that, listen, there's a coding clinic on this code. You may want to go check it out and see what is that about and see if it applies to your situation. In not all cases, you need to stop and go check out everything because that will slow you down, okay? But if you have a very complex case and you want to learn how to code that complex case, or you want to see if that coding clinic applies to your complex case, you need to go look it up. You need to look it up to see if that coding clinic applies to your complex case. So not all coding clinics is going to apply to your medical record of record. So that you're looking at the present time, at the present moment. So it's just there as an informational piece to say, listen, this is here. Use it if it applies. Don't use it if it don't apply. Is everybody with me? Everybody understanding?
Yes.
Yes.
Okay.
Yes. I got
Yes,
the
thank
book.
you.
Yep. All right. So that's how you interpret the coding clinic. Okay. So also, I'm going to throw in here, since we're in the coding clinic, you also have what's called a CPT assistant. Have you heard of that term before?
Yes.
No.
Yes.
No.
No.
Somebody said, all right, somebody says no. So the CPT assistant is similar to the coding clinic. CPT assistant is similar to the coding clinic, the same approach. You come across a procedure, you don't know how to code it, right? It's the first time you've seen this thing. You will ask your supervisors, they don't know. You ask your other co-workers, they don't know. You submit it to the CPT body, and they will be able to come back with an answer for you. In the front of your manuals, you will see instructions on where to submit your questions. Also, you may, because you may be privy to it, you may be able to go strictly to their website and be able to get information as to where to submit it to. Now, in most cases, in your entity that you're working for, if you're working for on the facility side, you will have coding auditors or coding educational units that are there set up for that primary purposes. In most cases, they're the ones who are going to be your go-to gurus that's going to be able to submit those questions to those respective bodies. So sometimes it's not you, but if you work in a practice where it's just you and only you, and you come across something very complex, this is what you can do. You need to know that this is a tool for you to utilize. You go to those entities and you ask them a question, and they will tell you how to interpret that situation, how to code for that situation. Okay? They will tell you how to apply it. So that's something, you know, that's like a helpline, right? You know, like coding clinic for 1,000, please, or whatever the case may be. That's your helpline. All right. There used to be a show back in the days where you used to have a call up a friend and that kind of thing. I forget the name of the show. That you can be able to do that kind of thing. So CPT assistant, coding clinic. You need to know that those two materials are out there for you. Now, they're usually published on a quarterly basis. In most entities, hospitals that you work for, they allow you educational time, downtime, for you to go and review these materials on your own. So it is totally you that's going to be going in and taking these educational classes, reviewing the material that's coding coming from them. Because every quarter, I guarantee you, I'm going to show you here in a second, you're going to have materials that's going to come out that talk about how to code something, because coders all across the United States are going to be submitting questions on a particular item, and coding clinic or CPT assistant is going to be the one that guides you on how to code for those situations. So the wheels just keep on evolving. So yes, you're going to learn general coding in school. You have learned how to code in order to pass your CPS and CPC tests and whatever educational tests or tests that you're going to take over time. You know the foundational coding. But as you go throughout your coding career, you need to know that this is what applies. Not only that, for the CCS exam, for HEMA, you need to understand that these coding clinics exist, because some of those questions on that test will be coding clinic based. They will ask you coding clinic questions on there. And that's why they say for the CCS exam that you need to probably have about a year's experience first, or two or so, before you jump on in to try to take that test. In most cases, you can pass that test right out of school. And a lot of students have done that because they had a proper foundation, and the school that they went to gave them the proper foundation, solid foundation to pass those exams. I need for you to understand that with the HEMA test, they will ask you coding clinic related questions. It has happened. That is a thing. That is a thing. All right. So CC, comorbidities, and those kind of thing. So 1 second. Again, it's going to keep doing this. So this is your coding clinic information, and there is your first quarter. There's your second quarter now, and each of these quarters for your coding clinics is gonna give you years, the years of publish. So here's another situation that you need to keep in mind. What happens in 2016 may not apply to 2021. Everybody following me? So you may have a coding clinic advice that came out in February of 2016 that says this is how you code this condition. But yet in 2021, you have a different coding clinic advice that tells you something totally different. So the question now is, which one do I listen to? You listen to the the latest one, which is going to be the 2021 coding advice. That's the one you're going to zone in on. Why is that? You may ask. The reason is because diseases evolve, conditions evolve over time, things just evolve. And so what may have happened to you 20 years ago, how you look at the disease process is not going to be the same in 2021 because things has just changed. COVID came. COVID has now put in front of us a whole new array of different diagnoses that is something that we have never seen before in our lifetime, because now we're seeing conditions and things that long haul syndromes and all those kind of things that these are all new to us. This is a new concept of coding that was not there before. So here you are with a COVID coding clinic that's going over how to code for COVID, how to sequence the codes for COVID, and those kind of things. So you have to look at those advice because the advice is there. Now, mind you, R05 cough, but we know that that cough code has now been updated to R05.9 if it's unspecified or where there's acute, etc. Now, we're going to have to give these doctors time to get caught up. Not all of them is going to be listed as acute cough. Not all of them is going to be listed as whatever a type of cough that is out there known to man. You're going to have to give them time to get caught up with this new way of lingo of talking. Sometimes it takes years, all right? But do the doctors go through the same thing we do as education-wise with these new codes? Yes, they do. The ones who want to learn of how to document these things properly so we can capture it. For the most part, we rely on the CDIs, the clinical documentation specialists, the ones are on the floor. Actually, the ones who work in hospital floor, we are relying on them heavily to be the one to communicate with the physicians. So let's listen. There's a new way of saying X, Y, and Z, and they have the methods of doing this is via queries. Usually, the inpatient coders are the ones to query, and we, for the most part, we still do. But the CDIs have really taken on that task heavily. They're the ones we rely on now to do a lot of the querying to the physicians to let them know exactly. And that's why CDIs are generally nurses. They're the ones who generally do this. You understand that? You know that exists. Let's keep it moving. So you have the coding clinics. You have the coding handbook here, the actual code book. The coding handbook will talks about the code, how to apply it, how it applies, and gives you scenarios, and you have to realize whether or not you have to basically be the one to say this scenario applies to my medical record. So yeah, this fits, this makes sense, yeah, this code applies to me. I am not saying to sit in an account for 20 minutes trying to decipher whether or not that codes apply to you. I'm not saying to utilize every time the coding handbook, every time the coding clinics. That's not what I'm saying, because that will slow down your productivity. There's no way in the world you can code doing that each on every account. That's not going to happen. You're going to have to code regularly. What happens is, what I'm saying to you is, I need for you to get an understanding is that you only utilize it when you have situations that you question. You have a situation, for example, a patient comes in with respiratory failure, COPD, and CHF, all three diagnoses. Now, you're trying to ascertain which diagnosis should be principal. Because as we know, in the medical coding field, the principal diagnosis in an inpatient setting is the one that drives reimbursement, along with the principal procedure and the length of stay, the discharge status. Those are the things that we look at heavily in order to drive the DRG reimbursement rate. So since I'm on that, and I want to keep it moving here because it's 10:43, I want to give you guys sufficient time to do the hands-on. This is what I need you to now look at. On this field, you can see the DRG relative to this case that we just coded. The DRG is 204. The weight of this DRG is 0.7936, which makes the total reimbursement for this case $3,484.71. Based on the fact that this patient is going to go home, discharge disposition, and the discharge date, the admit date. So again, the DRG is based on the principal diagnosis, discharge status, length of stay, age at the time of the patient was seen, the gender, all of those things are going to play into my DRG reimbursement. But your principal diagnosis and your principal procedure are the first two things you need to relatively look at. The last thing, length of stay, discharge status. Now, your discharge status is very, very important, because if you select the wrong discharge status, you're in trouble, because you might end up cutting it into somebody else's. For example, if a patient went to a nursing home, right, and you say the patient went home, when Medicare received that claim, they're going to see a problem. So they may either choose to cut your reimbursement or cut the reimbursement to the rehab center. Either or, somebody is not going to see all of their funds. Somebody is going to be left out of some money. And a CFO, which is your chief financial officer for your entity, is going to be knocking on your door and going to be asking a lot of questions. When I used to work for a hospital named Delray, I can call it now, Delray Hospital, a tenant-owned hospital, back in the days as an inpatient coder, the CFO's office was literally right next to the coding office. And we saw the CFO every day. The CFO was in and out of our office because they wanted to know how something coded, or how we can apply a particular code, or why we didn't code a discharge status correctly, etc. Because now it has cut into the reimbursement. See, what happens is, class, the CFOs does a projectile every quarter. They know what they're supposed to be taking in money every quarter. The buck stops with us as coders. So if we don't code it properly, everybody's not going to get paid properly. So the CFO is relying on us to make sure we can code it properly in order to get it out that door, or else nurse A is not going to get paid properly. The projectiles for next year is not going to look good as far as how much money, the revenue they're taking in for that entity. Because if they do a certain amount of cardiac cats, and they know this is what the cardiac cat reimbursement rate is for Medicare patients, and they do that calculation, but Jennifer A over here, the coder, is not coding those discharge status correctly, not coding those procedures correctly, then we're in problems. It's because a charge, or not being the code not being captured correctly, now we end up with a less reimbursement on the plate. So this is why all of this is important. So obviously now, hopefully you guys get the picture as why DRGs are important, why all of this makes sense now. And I don't know if it was explained to you like that before, but hopefully I did a good job in explaining it, and I wasn't long-winded. But you can communicate with me via chat if you understand. Yes, just type in yes. If no, and you need to go more, let me know. If I muddle the waters, let me know. So yes, you understand in the chat. Yes.
Yes.
Yes, or you can just talk. Yes. Okay. All right. Awesome. So that is how that works. So I need for you to understand that, because I mean, if you end up as an inpatient coder, you need to understand that not only inpatient coder, outpatient coding too, because you'll see why that's important here in a second. Now let's go to the outpatient route. Let's go to patient is 30, and now instead of DRG, we're going to select APC Finder, and we're going to hit continue. We're going to continue on the Medicare field. We're not going to change that. We're going to use Medicare as our guinea pig. Now here is how this is set up. Because we are doing a standalone encoder, we need to know the type of bill. Type of bill refers to the setting that the patient is being seen in. Okay, 131 type of bill refers to a hospital outpatient setting. So that goes on the UB04 claim form. In like the upper left hand side, you're going to have the type of bill is going to be there. These are, everything is numeric except for the patient's name. That's it, and the address that they live at. That's the only thing that is not numeric. Okay, so type of bill needs to be mentioned. Okay, if there's a condition codes, Now, condition codes are a whole different class. But condition codes are different class. One of these days, I keep promising you guys I'm going to do a billing class one day, but it's time. I really, one of these days. Let's just leave it like that. One of these days. No condition. We're going to select number one at all time for this practice purposes. We're going to select number one unless I told you differently. All right. So we're going to do here with one, and then you're going to do the same thing. Everything is the same. Okay. Fever. So R50.9, and then we're going to get over here, fever again, and then we're going to do I. Okay. Oh, that's another thing for folks. Instead of actually selecting it, you can choose to just do the number. So you can just, on this screen, just type the number 1 on your screen, advance to the next screen. You know it's unspecified. It doesn't say any other things in the medical record. You can just choose to select the letter I on your keyboard, move to the next screen, hit the enter button. Now you're done. There's nothing else to code. Hit the continue. All right. And you'll have your diagnoses. Just know this. I want you to keep this in the back of your head because it's not doing what I wanted to do today. So something has changed with this encoder. You're supposed to have an admit diagnosis, right? You're supposed to have an admit diagnosis. Then you have your other diagnosis, which is your primary diagnosis. So we know, based on coding school, hopefully we know, if you don't know, in the settings, you have different ways of saying these things. In the inpatient setting, we know it as a principal diagnosis. In the outpatient setting, we know it as a primary diagnosis. Did anybody not know that? Okay, so everybody knew that. Okay, awesome. So you have a primary diagnosis and you have a principal diagnosis. Outpatient, primary, inpatient, principal. So for our purposes, I don't know why, but system is not behaving with me today. You only have a primary diagnosis listed. I wanted to actually put in the admit diagnosis as well, but it's not showing up. So for our cases, this is what we have. Now, we're here. Here's your coding book. Here is your coding clinic. Here's your coding handbook. You can click on coding clinic and up comes that coding clinic on coronavirus again, because a lot of these respiratory conditions is relevant to coronavirus. So, you know, if coronavirus was not documented in your medical record, you will not even spend time looking at that. You will just keep it moving. If COVID was mentioned in your medical record, yeah, you may want to take a little time. Read that coding clinic on R50.9. That's how you're going to rely on this material. You're going to utilize it when it fits your medical record profile. If it doesn't fit it, move on. Okay. If I code a gunshot wound to the head and a coding clinic comes up about coronavirus, we know that has nothing to do with coronavirus. We don't need to spend no time reading a coding clinic on coronavirus when I have gunshot wound to the head mentioned here. So, but for the most part, your system is not going to do that to you. It will not. Okay. The system will basically give you coding clinics relevant to that diagnosis. That's what it will do. It will not give you coding clinics or CPT assistance not relative to it. Now let me show you on the procedure side. On the procedure side for CPT, let's do a patient who has removal of, and that's your code. Hit the enter button again, and then we're going to come to this screen, okay? And it's going to give you an edit. Medicare considers this as an inherent bilateral procedure. Consider removing 50 from this code, okay? So because the CPT code is reflective of a bilateral code, we can right-click, we can add a modifier by just selecting the drop-down menu, find a modifier that applies to what you want, add it, hit OK, and then the modifier is there. If we get an edit, we can go and review that CPT code to see if, in fact, what the edit is saying is true. We can look at a CPT assistant, in this case, and we can find the most relevant CPT assistant that applies to our situation. So the latest one is March 2016. So let's look at that one. And it asks, the question is posed by a coder. So this is, remember what I said in the beginning, These are all generated for both Coney Clinic and CPD Assistant from coders, right? How is removal of serum reported? And it says for impacted serum removal that requires instrumentations, and then it gives you example of those instrumentations, report this code. But there you go. This is how you're coding. So you're going to click the X to close that out. You also have coder dex references. Okay, in order to find out what we do wrong, we're going to do a quick lesson. History, go to history, click on that, and that's your pathway, okay? So that showed you what you did wrong. So removal of, and we click select, we spell type, therapeutic device, implant graft. Okay, no. So we're going to go back to removal. Click on the removal in the coding paths history, and it will take you right where we need to go. No, click on it. Remove, no, the first, yeah, that one. There you go, and it takes you back. Very good. All right, click that again. Okay, pause here because we clicked the wrong one. I think we need to click foreign body, number 5, because serum, it doesn't belong in a body, so it's foreign body. And we're gonna ear, right? We move from the ear, so we're gonna select ear, number 8, very good. And then we're gonna select serum, number 2, very good, and impacted, right? You can select either one of those, whichever one you prefer, because of time and you have to go. And then you can do that. Yeah, that works. And then you see how that works there. Okay, so now you have the code. You can hit the continue button. Very good. So there you go. There you go. And so this is how it interplays. 23rd, we're doing another session on this, on the 3M encoder. That's what's going to happen on the 23rd. Just in case, because I really thought I would had a large class, because I put out an initial fielder to see how many people would be interested in this, and I had over 100 people on the page said that they're interested. So that's why I said, okay, I'm going to need to divide this up into 2 classes. But this is always the case. What happens is people say they're interested, but they never show up when it's, the rubber hits the road. They always say they're interested, but they really don't.
Now, which one do you want me to do?
For the discharge status, let's always make it home, class. Always home. Let's say they home. Let's not make, we're not gonna make it confusing. All right, so here now, because this is an inpatient setting, we have an ambient diagnosis field. I'm not sure why they didn't do that with the outpatient, but whatever.
Yeah.
Let's go ahead and say the patient is suffering from headache. All right, so headache.
There we go.
Very good. All right, and let's say in the admit field, so you have your medical record the way it's set up. You have a history, you have an exam, you have a medical decision making. Whether it be the actual consultant report, whatever form of document you're looking at, you're always going to have a history, exam, medical decision making. So for documentation purposes, we're not going to go straight to the final diagnosis in order to grab the admit diagnosis, right? We're going to grab the admit diagnosis from the history. What is wrong with the patient initially that they complain to? They complain to the doctor. They say, not the triage nurse, right? We're not going to grab it from the triage nurse notes. We're going to grab it from the physician notes. This is what I am complaining of. So you on this screen, is very important when you do selecting your admit diagnosis, you select it based on what was stated at the time of the visit to the physician. So he says headache, you're going to select H, the letter H.
Because you don't get that from the assessment on the H&P or the SOAP note?
Yeah, that's where you're going to get that. And that's
okay.
it's going to be from the physician, right? That's the physician medical record. Because in a hospital setting, right, you're going to have the nurse's notes, then you're going to have the physician notes.
Oh, okay. Well, I'm thinking of the different parts of the note.
Yeah. So you have subjective, objective assessment plan. I know what you're talking about. So it depends on the medical record that you have in front of you. Some folks document it just like the way I just said it. Some folks document it based on history, exam, medical decision making. So there are different ways of documenting that, profiling that to you, the coder, so you can be able to capture that information. So it's based on what is presented at that point, how the medical record is set up. So so you have SOAP, you have the three key components of history, exam, medical decision making. So you have that format as well. So in most cases in a hospital setting, you're going to have history, exam, medical decision making. So you're going to go to the history to see exactly what is going on. So it says headache. So you're going to hit the continue button.
A little confused about where I'm getting the information, because I'm still a student and I'm a medical transcriptionist, so I'm like familiar with what I see on the reports. So when you say history, I think of the history of present illness instead of the assessment.
That's exactly what it is. The history of present illness. That's exactly what it is. Yeah. So on the so when you type it up, so in coding world, we have three key components of an evaluation and management code, which is history, exam, medical decision making. These three key components is how we code an evaluation and management code. A part of that history is different subgroups, which includes the HPI that you mentioned, which includes the past family social history that you mentioned. Then you have the exam portion of the medical record, which encompasses the review of body systems, which would be either respiratory, genitourinary, musculoskeletal, all of those body systems. And then you have the MDM, which is the medical decision making, which says, hey, this is how I'm going to treat you. This is your final outcome. This is your diagnosis. I'm going to give you a prescription, send you home. You're done. And that is your medical record in a nutshell. Then you have the SOAP methodology, which is subjective, objective assessment plan, which basically is the same thing. Only different is they call it different. They just word it differently. So
I'm picking the word from the HPI and not from the assessment, which
they're not picking up from the final impression, because the final impression is so you have to understand the coding concept is we go by the diagnosis after study for the final impression. For the admitted diagnosis, we go by what did the patient say is wrong with you? Why am I here? And that is that makes up the admitted diagnosis. So that is the one that you're going to capture first as your admitted diagnosis. Another key thing that I need to mention to everybody here that's listening and future listeners is that you also have a situation where some encoders, like for example, there's one known as Optum CSC. Have you ever heard of that one, guys? Optum CSC?
No.
Okay, Optum CSC is just like the encoder here that we're looking at. The only difference with Optum CSC is it gives you 3 reasons for visit field. And some of these encoders, 3 of them encoders, does give you 3 reasons for visit field, meaning 3 admit. So they will give you on your UB04 claim form, if you ever go to one, I challenge you, go to Google, look up UB04, and print out a claim form and have one physically to look at, so you have an idea why is it you have to code the way you code, and why some entities that you work for is going to set their things up differently. Now everybody is going to require the same amount of information from you as a coder when you're coding. Some folks is going to do it differently. On the UB04 claim form, it does allow you to code what they call reason for visit. And separate from that, it allows you to code for the admit diagnosis. And then it allows you to code for the primary diagnosis if it's an outpatient, and the principal diagnosis for if it's an inpatient, along with its secondary diagnoses.
Thanks.
So it can be broadened to that point. It can really go that far down. So it depends on the entity that you're working for and how they set up their group of software. So some entity may just say, hey, listen, I want to just strictly zero in on an admit diagnosis and a primary diagnosis, or admit diagnosis and a principal diagnosis, and that's it. Then some entities may say, no, 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 no. I want to make sure that all my pathology codes, all my radiology codes, all my whatever codes get paid. So to make sure the coder captures all the necessary information possible known to man to make sure those procedures get paid, I want to give he or she the ability to code just drop in a lot of diagnoses in there. And so they will expand it to say, listen, I want you to code 3 reasons for visits. I want you to code admit diagnosis. And I don't want you to code the primary or principal diagnosis based on the setting, along with the secondary diagnoses.
Oh, okay. Thanks.
Does that make sense?
Oh, definitely.
I can't scroll down on my chat, so everybody unmute and answer me and let me know that you guys are understanding it. Does it make sense?
Yes.
Yes.
Okay, all right. Hopefully I explained that. Good. I mean, that is how it's set up. So basically what I'm saying to you as a coder, when you're looking for a job, there's certain things that you have to keep in the back of your head. What encoder software are they working with? How is your system set up? What is the productivity rate of that they want on a daily basis? You need to know that, or have an idea in your head, if anything, the productivity rate, if anything, the software that they work with, so you can have an idea how fast you can produce those charts on a daily basis. So what kind of questions do you ask the recruiter or the HR person or whoever is doing the hiring? What software, and you're not being picky, but you just want to know, what software do you use for coding? So you can get familiar with it. You can go back and do your own research. And what is the productivity rate for my job? That's what you need to know. You're not going to know how much reason for visit fields to fill in. They're not going to tell you that, because they're going to say you're being picky when you get that far. But at least you have an idea, software and productivity rate. Then you know exactly how their system is set up. If you're using the Optum CSC, you're good. Optum CSC is an artificial intelligence community. It picks up all the diagnoses, and all you need to do is go in and verify the diagnoses and the procedures. You don't actually have to do hands-on coding if you don't have to. Some cases you do have to. It is not an encoder. It's not a 3M encoder like this. It's a similar approach. Epic, I don't know much about. I don't know much about it. I'm still trying to find information, but for those who work with Epic, God, stick with your job, love it, and stay with it, because Epic is one of those softwares, it's new, and once you get that job, you have to stay with it. Not a lot of people want to hire you to train you, and for those who do hire you to train you, if you do get in there, stick with it. Anyways, let's go back to this. All right, quickly do the cough and then pneumonia. Do a cough and then pneumonia. Cough unspecified. Unspecified cough to number 1. All right, unspecified. All right, and then hit the add diagnosis button or continue, and then hit type pneumonia. And watch your screen. Watch the screen. Okay, when you were typing a while ago, did you notice something there happen? It automatically start populating, right?
Yeah.
It automatically started populating prior to the thing coming up. So hit the back button. I just want to show you guys something really fast. This will help with your productivity whenever you go on a job and they use the trim encoder. Oh, whatever encoder software you use, for that matter, this is how they're set up. If you start slowly, start typing pneumonia. Don't go rapid. Slowly type in pneumonia and watch the screen while you type in.
Okay.
See, you automatically start populating it. So you can just go down and select it, and then you can hit number 1. This will help with your productivity so you can navigate much faster. Now, because you just know it's pneumonia, has nothing to do with anything else, hit G, and then associated influence, no. And then 1, no. Do not wish to code anything else. You're done. No, nothing else. So the number 1, you're done. We're not doing any advanced coding today. Just hit number 1 for me. on your keyboard.
Oh, I thought I already hit that. Yeah.
You didn't take it. And number 1 again. All right, J18
Okay.
and continue. And then hit the continue button. All right, okay. If we do have a class on the 23rd, everybody here that's here is welcome to come back, okay? If we have a class on the 23rd. But I have to have registered first before we have I can make that determination because of but then I want you to do me one more favor. Let's do a CPT code. So we're going to hit the next patient button. We're not doing inpatients today because that is going to be, so we're going to select the product, APC Finder, and then we're going to select the age. We need to put in an age, whatever that you want it to be. It doesn't matter. Okay, hit the continue button, and then number 1 for up, yep, and then we're going to type in, okay, and number 7, okay, all right, the H. Now we under the primary diagnosis field, so let's go ahead and say it's a migraine headache, number 3, and then I, letter I. Very good. And then number 7 for unspecified, and then number 3 for other unspecified, and then number 2 for other unspecified, and number 1. Okay, so you have headache unspecified and then migraine unspecified. Now, if the 2 in the real world, what would happen is you would just code G43909 unless the coding rules change. Hit continue for me. So you have headache as the principal, as your admit diagnosis, with migraine as a secondary. Now, if you notice on this chart, on the grouper software, because we're using a standalone version, has not built in the price factor when it comes to this. Because on the outpatient side, you have different variables that you have to work with. Insurance carriers primarily have their own set of contracts that says this is how we're going to pay for particular services, for particular patient types, for particular work groups. When I say work group, I mean actually companies that you employ for, etc., etc., etc. So all the information where that is concerned is different. So there's no predicament of what the payment is going to be. But there is a primary factor that we work with when it comes to certain procedures like the evaluation management codes, etc. Okay, but major procedures like heart surgeries, etc., that may be done on the outpatient side, those are factored in differently. So that's why you don't see any price factor. You only see it on the DRG grouper for the standalone edition. Hit the next patient button. I'm going to pass this on to somebody else right now because of time. And let's see.